Welcome, everyone. I'm excited to welcome you to this episode of the Sunflower Podcast, a podcast exploring all aspects of children's palliative care around the world. Sunflower Podcast is bringing curiosity, humor, and reflection to the world of palliative care. We're exploring the joys and challenges of working in this incredible field, including topics related to education, advocacy, self-care, service provision, and leadership from around the world. My name is Rachel Neufeld, and I'm thrilled to be here as a guest host for this podcast. I'm a pediatric palliative care nurse practitioner in Vancouver, Canada, working for Canuck Place Children's Hospice. I had the privilege of traveling to Nepal and Bangladesh with Two Worlds Cancer Collaboration this year, teaching, mentoring, and supporting the growth of children's palliative programs in South Asia. Join me in a 3-part series, Through a Nurse's Lens, where I talk to 3 nurses at Canuck Place Children's Hospice, each with a unique experience and perspective. We talk about the pearls and pitfalls of this beautiful work and how each perspective changes how we approach our work. Today I had the pleasure of sitting down with Rachel Schmidt. She's an RN who's worked at Canuck Place Children's Hospice for 5 years now, with a previous experience in adult palliative care. Today we want to explore, from a nurse's lens, some of the differences and shifting focus towards pediatric palliative care and the things that she's learned. Hi, Ray.
Hi,
It's
Rachel.
so nice to see you. We have both Rachels.
Yes.
I wonder if just for the show, if you could introduce yourself, what your role here is at Canuck Place and kind of how long you've been here for.
Yeah, so I'm Ray, and I've been working at Canuck Place Children's Hospice since 2019. Came from a palliative adult background, and then I came here and started at DLH in-house, and I worked part-time for a little bit, and now I'm full-time for probably the last 2 years.
Okay.
So, yeah, it's
Great.
been good.
What I was hoping to talk about a little bit today is your experience as an adult palliative nurse and coming now to pediatric palliative care, and some of those differences that you have seen, some of the learnings that have been most important to you as you've kind of gotten into the pediatric world, and kind of explore how we do pediatric palliative care that has really become paramount to you, coming with quite an extensive sort of adult palliative experience. So I wonder if maybe we can start with highlighting some of those big differences that you've noticed coming into pediatric palliative care.
Yeah, so there are a few things that do feel different. A lot feels the same, but there are a few things that are unique to pediatric palliative. I think the 3 that stood out to me were just the way in which we approach collaborating with families in talking about next steps and care for their child, kind of more of a family-driven versus medical team-driven. And then a little bit about just symptom management assessment and how that looks so different in pediatrics versus adults, of course. And then prognostication and like goals of care conversation feels very different.
Totally.
Yeah. So in regards to like the family-driven conversations, I think that in adult palliative, the team often will like take the lead when it comes to next steps in regards to like medications that we give. Like oftentimes it's the team collaborating, making a decision, and then proposing it to the family. But I find that with pediatric care, we're chatting with the family from the get-go, and we're often asking, what's your baseline? What are you used to with your child? And then as we look at symptoms, as we make changes, it's all in collaboration with the family. So we want to try this medication. Does this feel reasonable to you? Have you tried this already? It might be attainable in-house in the hospice, but does sub-Q medications actually feel doable for you at home? So I feel like that felt big coming here. And then another thing I think we do really well in pediatric palliative is entering into serious illness conversations. And that looks different with adults. I think that oftentimes the family team meetings are kind of quick, but here we're really good at creating space and saying like, tell us about you. what's working right now. We follow a serious illness guideline, which is wish, worry, and wonder. So it happens in those like meetings, those bigger family team meetings, or those serious illness conversations. But then we've also talked about how that happens at the bedside too, and using a really specific language of the wish, worry, wonder that I hadn't even been introduced to in the adult palliative world, which is kind of interesting. So, being at the bedside and talking to a family, and maybe their child is having a lot of feed intolerance. And so we're saying, like, I also wish that your child doesn't need to have a G tube. And that is distressing. And I'm sad that that's the next step. But, like, I worry based on what we're seeing, and your child is puking all the time and he's really upset right now. And I wonder if, like, this is showing us that he's changing, and now we need to step into something different, even though it's scary, even though it doesn't feel fun. So that felt new to me.
Right.
Yeah.
I'm curious about your experience, like fairly newly to pediatric palliative care, when you're having that kind of wish, worry, wonder conversation at the bedside. My experience has been that it allows me to align with families and create a more trusting relationship with them before we express some of our worries. And I guess I'm curious your experience fairly new to this, like when you first got into this pediatric world, the wish, worry, wonder framework, in how those conversations went for you and how the family responded to that kind of language. And like maybe if you have some examples, or using that framework at the bedside for nurses, how that experience was for you, and sort of how the family responded to you.
I think that in the beginning I definitely stumbled, because it's weird to have such specific language. And it feels like when you have specific language, it feels initially when you start those conversations inorganic, maybe because you're like, I'm going to use this word, then this word, then this word. But like you say, initially, when you can kind of come alongside them and agree in what they're experiencing, and they can say, my nurse gets me in this, or my nurse sees me in this concern, and is then able to, like, then gently, I really like the worry, because then it's that kind of like, this is my pondering. Is this your pondering also? And then stepping into, like, the wonder that doesn't feel aggressive. It doesn't feel like these are your options, choose now. But it's kind of like, let's talk about the next steps. And it is well received because it's gentle and profound. You're not flubbering over your language either. Kind of, it gives you this direct kind of framework to work within.
Yeah, I've really liked it for that reason, because the I wish, we hope alongside you. Yeah. We wish that this would have worked, or we hope that this might improve. And so you get to align with the families in their hopes, and that they can see that we also hope with them, that it is not without hope. So helping frame that hope, but then also be able to express within our medical expertise what we're seeing.
Totally.
And then the wonder, I love that too, because it allows us to give recommendations in a compassionate way that doesn't feel like we are making demands or statements. It's more of that family shared decision making when we give wonders.
Yes, it feels very collaborative. And I do love the hope, because I think that in palliative care, a lot of people feel like there's not much hope. Or when you get there, there's not this hope. But to be like, there is hope in moments of like, I hope that my child can experience this one thing, and maybe we provide that through Canucks, through or make a wish or something like that. But then also, like, bringing you back to reality softly.
Something else I've learned about doing the wish and the hope is the concept of redefining hope. So there may not be a hope for cure or for fixing the problem, but we can hope for comfort. We can hope for time spent outside. We can hope for experiences as a family. And I like that that framework allows us to help families reframe, redefine their hopes, and that we really also want to celebrate those things with them as well, that it isn't all the worries, that there are good things to celebrate along the way too. I'm curious if you have any stories or examples of when maybe trying to do family shared decision making did not go so well.
Definitely. Yeah, I'm trying to think of one off the top of my head.
Or maybe general ways that you have found, like what are some of the instances or the areas in which that becomes more difficult for you?
Yeah, I think that anytime, a child is very symptomatic or really doing poorly, stress is heightened. And so you have a family member that's now doubting if we're doing the right thing, feeling upset that maybe they're involved in, bringing certain feelings upon their child, say, or like, yeah. So then in those situations, I feel like it's hard to propose those other options because oftentimes, like, those recommendations don't land in the same way, or we get stuck in our worries, or they're living in their worries. And so, we bring that to light, and then it's like, don't talk to me, I'm already so stressed about that. I don't want to. Or another time that's felt tricky is when a family has had another experience or heard of another experience from a different family.
Yeah.
And so we're trying to step into that hope, into that worrying and wondering, but they're stuck in one spot because they were already told that intervention doesn't work or that approach doesn't work. And so then I find sometimes that's a hindrance.
Yeah, family are going to come with their own lived experience.
Yeah.
And then also as a medical team, we all come with our own biases and perceptions and beliefs as well. And I think for me, the hard part is that we try to avoid a sort of directive care sometimes where we're trying to do this shared decision making, but also families maybe don't know what they don't know, or they have their own biases. And so then how do we come to somewhere in the middle where we have an obligation as medical providers to be using our expertise to be making recommendations for what would benefit the child, what would be in their best interests, while we're also meeting families where they are and what their goals are and their understanding is. And maybe that's incongruent. And when that understanding is incongruent, I think is where there's a lot of distress amongst care providers in terms of how to continue to make shared decisions with families.
Absolutely. And I think that that's a piece of the palliative journey that's beautiful within pediatrics is that we start with these families from when they're babies sometimes, and we're journeying with them for 5 years, say, until we actually step into this picture of end-of-life support. So even if one of these conversations doesn't land, we've often built good relationship. We have rapport with this family, and we're able to hear them out and then share in an honest and transparent way, and then kind of land in the same place. Most often, I would say, with our families, to provide that good palliative care that we know is so necessary, no matter where you're on in your trajectory.
Yeah, and I feel like that leads into one of your other comments then about prognostication and how difficult it is in pediatrics.
Yeah.
And the fact that we follow children for so much longer throughout their trajectory, that we might have them for 10, 15 years on our program.
Yeah.
And I'm curious to hear from you, at least initially, like what some of your learnings were in terms of how we might be providing prognostication and how do we think about that, which is quite different than the adult world. So in that pediatric lens, what have you learned about doing prognostication or helping families within various goals of care as we kind of follow them for sometimes short and sometimes longer stretches of time?
Yeah, so in the adult world, we often have a specific populations that's often cancer population. So we have the progression of disease based on metastases of cancer most often. And then we kind of come into the picture having those goal of care conversations quite near the end. And so we're often able to come alongside them in that moment, and then that moment passes and we move on. And so a big learning for me was that palliative care starts right at diagnosis almost for these kids. And so these babies get their diagnoses, and then our team steps in and says, okay, how can we support you then? And these goal of care conversations, these serious illness conversations, they're happening right away. And so it's cool to then be able to journey, and we journey so much more of this story with these families. And so prognostication, it can be tricky because we talk about, there's a child's baseline and then there's their fragility within their baseline. So it's hard to say that maybe their diagnosis says that they'll have 5 years of life, but then they have a really bad resp infection, and we're kind of coming alongside that family and using all of our skills and our knowledge and supporting them, hopefully guiding them in that moment. But it's interesting doing a bit more of that timeline than in adult, and then in adult palliative, and then in the same way, then goals of care happen in a different way because sometimes they change. And that was a big difference for me too, because in adult care, when you go into hospice, most often you're an M1 or an M2, so you're not having many interventions.
Meaning goals of care are comfort focused.
Yes, are comfort focused all the time from the get-go, for the most part. And then in pediatrics, we have our full codes, our babies and our children. We're doing full interventions, and that's not wrong. It's not that can't be, but it's interesting to navigate that. As a child's changing, you're having these wish, worry, wonder conversations, but also knowing that they do require full intervention. That was a big learning curve for me.
And I think that that's something that can be both rewarding and challenging to navigate. And again, trying to find that middle ground of what our medical recommendations would be in terms of what we believe to benefit the child, what's in the child's best interest, and where the family are within their goals. And I think, again, that wish, worry, wonder framework and the serious illness conversations allow us to explore with families and really gain good perspective on their understanding of the situation. And often they're going to see things that we are also seeing, and maybe just don't know how to verbalize them or how to talk about them or things like that. And so that's where we can come along as well in terms of navigating the changes. But yeah, a lot of our kids on program are going to have years of fluctuations in their care plan and their fragility, and it isn't a linear thing. And so along the way, we get to repeat conversations and we get to come back to them. As a nurse at the bedside too, like one of the things that I'm learning as we train serious illness conversations is, how do you guys use some of that languaging and that framework at the bedside? So I'm hearing too is that ability to reconnect with family using some of that approach as well, even if it's a new symptom that has come up.
Definitely.
And so I guess I'm also curious that leads into some of the symptoms that are unique in how we navigate a lot of the population that we see on program, a lot of which have neurological impairment, metabolic impairment, genetic changes, things like that. So what are some of the symptoms that maybe you have had to learn quite differently? And then maybe what are some of the ones that are challenging to you, and how have you maybe approached it? What have you learned? And some of that nursing lens of how you manage different symptoms with some of our kids.
Yeah, absolutely. So with adults, again, the interesting thing is that, or the normalcy of it all, is that they're just communicating with you. So they're in pain, they're asking for analgesic, they're really able to express their concern. What's going on in their own body, they know them. And so we're able to then respond in a very kind of simple manner of, yes, I'll grab that medication for you. Absolutely, let's do this non-pharm intervention. But for pediatrics, I feel like my assessment skills are just amplified, and they're so thorough and that was new for me too. Like I had to learn this whole new way of assessing because I was going from adult to pediatric for the first time. And so I was learning how to communicate in ways with our non-verbal children, so the metabolic kids that you're talking about, the genetic kids. And so I feel like with say like feed intolerance, I'm not just asking, are you nauseous? Do you need something? It's kind of like looking at the whole child. So are they lip smacking? Are they reflexy? Are they diaphoretic? Are they breathing differently now? Do I need to change their position? So it's me, just my assessment skills are just totally more amplified, I'd say. And similar to pain, we would look at facial grimacing, grunting, moaning, maybe guarding of a limb, or those kind of things, teeth grinding. And then we're using different pain tools. So we're using the FLAC tool, we're using nitpick, we're using the faces, different ways to communicate with these kids because they're nonverbal. They can't just tell us what's going on. So that's been big. And shortness of breath too, like work of breathing, position changes, fan, oxygen, different things like that, cool cloths. We have a real big focus on non-pharmacological interventions in pediatric palliative too, which I think is cool because in the hospital we tend to just kind of go medication route right off the bat. And so it's really cool to explore like massage and warm blankets and comfort toys and position changing, that kind of thing, distraction, touch. So that's been a huge learning curve for me when it comes to my symptom management assessment of my patient.
Yeah. I'd love to get a little bit more detail into like your one example of feed intolerance.
Yeah.
It's so hard to make any kind of definitive diagnoses around feed intolerance because it's usually so insidious.
Sure.
Right? It happens over time and maybe over years that we've followed a child where it's just never quite back to baseline or their tolerance just becomes less and less. And from a nursing lens specifically, what are some of those things that you lean into? Like, how do you manage when you're seeing some of those signs of feed intolerances? What are some of those nursing and maybe the non-pharm things that you do to help manage feed intolerances before we go to medications?
Yeah, absolutely. So oftentimes initially we'll stop the feed and we'll give the gut a little bit of a break and see if that's the solution right off the bat, because that can be really helpful in telling us like, oh, this is not really working. And then oftentimes we'll slow down the rate. We'll make adjustments to the rate. So maybe we start for 20 minutes or 40 minutes at a certain level, 50 mils an hour, and then we increase it to 75, and then we increase it to 100, and we see if that is a helpful adjustment. Oftentimes we'll change position. We have GJs, so we're sitting our kids upright. We're never lying them down when they're feeding. Decompression. Sometimes you just need to stop that feed, let some air out, see if that's helpful in that moment. And then sometimes that's all it is. Their gut's just really irritated, and that's out of the way, so then they can tolerate the rest of their feed. So there's some of the things that we would do.
Yeah. And I would just add to that too is that then we continue to loop back to that wish, worry, wonder framework of kids that we've followed for years that have had ongoing changes of feed intolerances that allow us to then get to a point where perhaps they have reached end stage gut failure and end stage feed intolerance, where we can then look back with parents to say, like, what have you seen? And we've seen that too. And so we worry that this is now their sign to us that they can't tolerate food anymore. And it's allowed us to really meet family in a supported way that we've all come to agreement of when and how to stop feeding a child towards end of life. Because I think that these children who are fed through tubes, it's so easy to just keep putting food in. And we know that there are natural progressions of diseases where the body's natural changes are to eat and drink less. And when we don't allow for that because of tubes, that becomes a very gray area of when and how do we pull back and stop feeds even towards end of life, where we can then really have supportive conversations with families that this is what we're all seeing. And now this makes sense to stop feeds because they're clearly showing us that they can't tolerate this food anymore. And so I think that the work upstream, that early work that you talk about of let's stop it for a little bit, let's try this, let's try that, then over time, maybe it leads us to actually getting to a newer place with families where they recognize maybe their goals shift to maybe feeding for comfort instead of growth and development, and all of those kinds of changes that families need to go through over time about their feed intolerances. Because I feel like that's a symptom that doesn't have definitive medications that help.
Absolutely.
So I think that it's a difficult one to manage. So I think that the nursing perspective and on the floor, at the bed, those changes that you guys do to adjust are way more important often than any medications that we might be giving. So I think that that's a really good one for people to review, because it's such a gray area that doesn't have any defined rules around it. I'm curious, you talked about like work of breathing and secretions. So I guess, are there nursing lens interventions, like nursing interventions that feel really important to you when you're considering like looking at a child that's got increased work of breathing for this same kind of population, maybe that is tube fed, maybe has neurological impairment, and you see increase in work of breathing?
Yeah, absolutely. So a lot of our kids do struggle with secretions, especially our neurological kids. And with fluid volumes, we see those secretions being an issue because their body just isn't able to clear up the fluid in the same way. And so their lungs just aren't doing the job that they need to. So oftentimes what we'll do is we'll need to do a lot of like stopping the feed, venting. We'll often do a lot of postural drainage, which is really helpful. We do lots of nebs.
Can you tell me a bit more about what postural drainage means?
Yeah, absolutely. So in our kids, we find that putting them in reverse Trendelenburg on their side, or maybe it's a baby and you're holding them, supporting them with their head downwards, and they're kind of face to the side, then they're able to just kind of through gravity drain all of those excess secretions so that they're not pooling in the chest because maybe their muscles or their lungs, whichever one it is, isn't able to clear up those secretions independently. So that position just allows for them to do so. And then when we're giving a neb alongside that, loosening the secretions when we're doing that chest care of like chest pats, chest physio, that mobilizes the secretions too. And then especially with that extra gravity, oftentimes they're able to clear it. And sometimes we'll keep them overnight like that to help and support. And then of course we're suctioning quite often if necessary. And those are the main things.
So you actually consider putting these kids onto side lying and or possibly head down position instead of head up.
Correct.
And in a high Fowler's, which tends to be sort of a reflex of medical care. If someone's having difficulty breathing, we try and sit people up.
Put their head up.
That isn't necessarily what is helpful for some of these kids, and to actually think about a position, including slightly head down or onto their side, where they can actually drain their secretions a little bit. And you mentioned neb, so just a little bit, like what do you use as a nebulizer? What are you putting in there?
Yeah, so we're using normal saline often. Sometimes if the child has a prescription of salbutamol or ipratropium, we'll use those also to open up the airway to help if they're struggling. But often the saline just to loosen the secretions.
Yeah, thin the secretion.
Thin the secretions, yeah.
Allows them to drain out a little bit better.
Absolutely.
And then what do you do about fluids altogether? Because you mentioned stopping the food. But if it's a secretion and a work of breathing issue, what are we meaning about stopping the food and the fluids?
Yeah, so we'll stop the food so that their total fluid volume is kind of on pause, because if they're getting refluxy, if they're coughing, then it just is all kind of happening at the same time and causing a bigger issue. So if we stop the food, we kind of slow down that process, and then we can minimize the secretions at the same time.
Yeah, and then looking at their total fluid for a whole day, as a lot of kids with neurological impairment actually seem to do better at 60 to 80% of a total calculated fluid volume, as opposed to a child who moves and functions more normally. And I think that's something that a lot of practitioners don't really make that connection quickly or first, in that the total food that they're getting and the volume of the fluids that they get can actually affect their respiratory secretions. So one of the things, if the secretions are copious, that we can look at is their total fluid for a day and whether or not they might actually do a little bit better with a reduction in that. Well, thank you so much for taking the time to talk to me today. I love getting a nursing lens perspective because so often we think pharmaceutical, what can we give them to improve a symptom? And so often there's other things that the nurses are doing at the bedside because you're the ones there 24/7 looking after these kids, right? So that nursing lens is so important. And I loved hearing the perspective on how we actually meet families where they are, to use that wish worry framework. I love that has become such a powerful tool for you.
Absolutely. Thank you so much for having me.
Thank you for listening to this episode of the Sunflower Palliative Care Podcast. These podcasts grew from a seed of an idea as we talked with our colleagues in the Sunflower Children's Network. The Sunflower Children's Network is an initiative of Two Worlds Cancer Collaboration, which focuses on children's palliative care. We hope to build a world where no child suffers from serious health-related issues. To learn more or to donate, please visit twoworldscancer.ca.